Madam, shall we, madam?
You can start, sir.
Okay.
Good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is myths and fact about male infertility. I welcome all the participants and request you to post your queries in the comment box so that we can have a short Q&A session at the end of the presentation. And now it's time to introduce our invited speaker, Dr. J. Kritika Devi, ma'am. Madam has completed her MBBS from prestigious MMC, Chennai, and MD from MD OG from Jipmer, Pondicherry. Madam is currently the consultant in Nova IVF Fertility, Chennai. Current president, International Fertility Research Foundation. Executive committee members for IFS TN chapter. Madam has a fellowship in andrology and reproductive medicine, Chettinad Hospitals and Research Institute. Undergone training programs in reproductive medicine at Glen Eagles Hospital, Singapore. And Madam has also authored a chapter titled Frozen Embryo Transfer Protocol for Handbook on Ovarian Stimulation, and also published various research articles in national and international journals. So with this, I welcome you, ma'am. And before going to session, I would like to share our Shield Connect web page, ma'am, so that I will give a short introduction on our web page, ma'am. So this is our Shield Web Connect web page, ma'am. So you can see the various blogs from our experts, ma'am. Our doctors used to share their research thoughts and advice through blogs. So you can see the various blogs written by our experts in our website, and there will be a column for webinars. So all the webinars from Shield are connected through our Shield Connect web page, ma'am. And you can see the list of upcoming and sir, you can mute, sir. Krishna, sir, you can mute. Yeah. So you can see the list of upcoming webinars and past webinars in our webpage. So all the details are available in our webpage. And we have another page for our leaders, ma'am. So you can see the our leaders page where you can see more than 220 doctors supporting our webpage through their webinars and their uh, sort of research works associated with us. And you can see some details on GDM day on March 10th. We have that National GDM day, so you can find a short videos on gestational diabetes given by various experts are available in our web page now. So I request the participants to go through our web page and make use of it. So over to you, ma'am. Now we can start your presentation.
Thank you, Stalin. So, a very good evening to one and all who have logged in today. And I want to thank Shield for giving me this opportunity where we can share our experience and ideas with the fertility experts. So, I want to first thank them for giving me this interesting topic, male infertility myths and facts. No other area in reproductive medicine would have been surrounded by so many myths and misconceptions, both among gynecologists and also in the public. So I thought this is like one area where we can have a discussion about what does evidence say rather than what we believe in it. So let me start the presentation. So let me directly go to the myths first. The most common problem, especially in our country, that I come across day to day is whenever there is a concern of infertility, I see only the women sitting in front of me. She'll be accompanied either by a mother in law or her mother. Her husband, the hero, will never be in the scene. So it takes an effort for us to convince them to bring the husband into the scene and to make them understand that he has an equal role to play in infertility. So that is why I thought I'll start with the first myth: fertility or infertility is a women's problem. And it's only the women's health that matters when it comes to having a baby. And sadly, it's not only the patients. I've come across a lot of prescriptions where women would have been subjected to a lot of tests, including a HSG or even a laparoscopy. And finally, when nothing works, then they turn into the man to find that has a sperm analysis of azoospermia. So all our efforts and the medications that the lady has taken becomes a waste of time for her and waste for her health also. So that is why let's move on to the fact that whenever there is infertility, remember, when you equally divide into three portions, there is one third where exclusively the female is responsible. For example, there can be a premature ovarian failure, anovulation, endometriosis, clear cut involvement of the female partner. Similarly, there can be another one third exclusive involvement of the male factor alone, where the female is absolutely normal and the problem can be, say, for example, azoospermia or severe OATS. The rest of the one third can be either a combination of both male and female factors, or it could be a case of unexplained infertility, right? So when we know that male can have equal problems like females, which can lead to infertility. So, what is preventing us from starting with the simple semen analysis before we start any treatment or plan any management for the female? It's one of the easiest tests that can be done. So, personally, as they say, I start with the OM. First OM will be the husband's semen analysis before I start or plan any treatment. So it is the semen analysis which will actually guide me whether they require a simple ovulation induction or a natural contact or an IUI, or I'll have to go for ICSI. So the next common myth among men especially is, when I have sperms, that's enough. How does lifestyle affect me at all? Even for clinicians, when we know that evidence says lifestyle matters, we can counsel them in a much better way. And these are the factors which we have to reinforce during history taking, that whether they are taking cigarette smoking as a habit or alcohol as a habit has to be elicited during history, because it has been proven that both can affect the semen parameters. And some can be bodybuilders who can be using steroids. And nowadays, the most common issue is the occupational hazards. There are a lot of men who work as a chef. There's a lot of people who work in factories with high heat exposure. Coming to chemicals, I have a particular place, especially near this Balajabad, where there are a lot of leather factories, and I find so many men with severe OATS or azoospermia. So probably the exposure to the tan and the chemicals that they handle during their work causes a deleterious effect on their semen parameters. Now coming to this paramedical line, X-ray technicians or even doctors who are exposed to radiation, they all have a risk of having a low sperm count. And of late, we find a sudden surge of IT professionals working with US timings who do a lot of night duties. So men who are having this night shifts, I find them to be under a lot of stress, and that in turn can cause a deleterious effect on their fertility. And remember that changing a lifestyle can bring out a very good improvement in their chance of fertility. And at least the lifestyle change has to be maintained for about 2 to 3 months before we start a treatment, because we all know that the whole spermatogenesis takes a span of 60 to 90 days. So this is what evidence says. There is a significant decline in male infertility, especially with advancing age, incorrect lifestyles, and environmental factors. And we find that there is a risk of decrease in male fertility. And yes, it is an important public health issue in this century. I'm sure all of you would be handling male partners who are just addicted to either smoking or drinking. And I've had personal experience when I say don't smoke or don't take alcohol. I've seen men with a very casual attitude who says, Madam, my friend though takes 10 cigarettes per day and he has 2 kids. My another friend is a worse alcoholic than me. He has kids. So how me taking just 2 or 3 cigarettes per day or just taking 1 or 2 pegs is going to affect my fertility? So this is a very common uh, concern raised by the male partner who wants to take a shield for what he's doing. So for these men, I would always say, for example, don't go on Saturday nights driving on ECR. That is a main road in Chennai where it is accident prone. So they will say, my friend who traveled in that road didn't get an accident. So why should I be scared? I would say he was lucky that he escaped an accident. It doesn't mean that you don't have a risk. Similarly, for men with addictions, I would say their friends are lucky that they had kids, but you don't have a kid. So it is important that you stop all these addictions, because it is proven that consuming alcohol can impact your sexual drive. It can cause a problem with your erection, and that can affect your sperm parameters also. It can cause an oligospermia, and it can cause a lower seminal volume, and it can affect the motility. Similarly, smoking again can affect every parameter of your semen, and hence has to be counseled that they should be stopped. So this is what science has shown us. Definitely, after stopping these smoking or alcohol or other pan parag and other habits, we find a better success rate. And the next common problem in this century is stress. Not only for men, I find a lot of women also going through the stress. And there are work where they are given targets, and if targets are not achieved, you don't even have a job security. So men become so tied up to their work that their mental stress is always high. And it has been again proven that stress can do havoc for your fertility. It can affect one's sex drive and can affect the semen quality and quantity, and can be a leading factor for infertility. So these are various studies that has worked on the effect of stress on fertility. So right from motility to the concentration to your sexual function, we find that stress has got a deleterious effect. Again, using a lot of mobile phones all the time, or keeping laptops on your lap and then working, all these may have a deleterious effect. This is an interesting study which said use of mobile phone for more than 4 hours per day was associated with increased sperm DNA fragmentation. So all these electromagnetic radiation, both from the laptop and your mobile phone, can have a deleterious effect. So these are the banes of modern era. Okay, now coming to the other common misconception, I find it very common in the public, the concept that if a man has zero count, they equate it to he can't have a normal sexual life. In fact, I have a lot of women's relatives who ask me, his count is zero. So how will my daughter have a normal sexual life? So this is totally two different compartments. Erection is one different compartment and fertility is a different compartment. So for erection problems, the cause can be neurological or it could be pathological. There is a problem with the neurotransmission or there could be other issues. But for fertility, all you need is one sperm. So a man can be azoospermic, but his testosterone levels and other things, if it is normal, hormones are normal, he can have a normal sexual life. On the contrary, a man can have, say, a count of 80 million with good motility, everything normal, but he can have impotence. He can have erection problem. So it is important for us clinicians to counsel the patients that both are totally dissociated and most of the times impotence could be psychological, which can have to be addressed separately. Whereas fertility is a different issue and that can be handled separately. And most of the times I've seen that whenever there is a psychological problem causing impotence, the bottom line could be their anxiety that they're not having a child. So most of them, when they conceive with our treatment, the stress level comes down, the pressure comes down, so they perform better in their sexual life too. And this is a very, very common myth from time immemorial, I can say, for ages. So there is always one casual attitude or a callous attitude that what is there for men? They can even father a child at 80. So the women is only the main reason. Whereas this myth has been broken and it has been proven that with age, men also have got a negative impact on their fertility. So this is something very useful for clinicians when you counsel an older elderly couple, where we can tell them that it is important that they have to start their treatment early because men also can have problems. I'm sure some of you would have had couples where the men will be in 40s and the girl would be in her early 30s. And the man will say, what is wrong with me? I have a normal sperm count. So it is essential to make them understand that even for men with advanced age, they can have a negative impact on their sperm parameters. And remember that for men with advanced age, we have found that there is a high risk of miscarriages for the women and they can have a lower semen volume, they can affect motility, they can have a lower motility and a lower number of normal looking sperms. So teratospermia also can be more. So whenever the man is elderly, there is a risk of having a genetic problems with the offspring. So these are important factors for for us gynecologists to counsel the couple. So this is again a study which shows that with age, the fertility declines for men too. So again, this is the other side of the coin where we have young women, young men. So he'll be just 26, recently married for say few months, but his sperm count can be zero, azoospermia. And then it becomes even more harder for the family to accept that he has a problem and they had to go on with the treatment. So especially when the man is azoospermic after repeated, say 3 or 4 analysis, and we have to tell them that testicular biopsy and ICSI will be the only option. It is such a big blow to the entire family, and it becomes difficult for them to accept that although he's young, although they are married for a shorter time, still they have to go for a higher treatment. So it's important to understand the other side of the coin that even young men can have infertility problems. Absence of sperms or severe oligospermia can be seen in younger age also. So that is why again I want to reiterate what I told in the beginning. It is important to do a semen analysis whenever you see a couple who want to have a child, whatever may be the age of the husband be. The next thing is with modern food and modern lifestyle, we find that there is a lot of medical factors that is coexisting in men. Most common that I see is diabetes, hypertension, psychiatric problems, epileptics who are on medications. So we find that whenever male infertility is associated with medical problems, the medical problems per se or the medications what they take can have an impact on fertility. For example, diabetes, if not controlled, I frequently see that these men have problems in collecting their semen sample. So, whenever I note down that the man is a diabetic, I make sure that he has a frozen sample if he has any difficulty in collection, or at least please ask in the history whether he has problem in semen collection, so that whenever if you're planning for an IUI you can have a backup sample frozen. So that's why it's important to rule out medical factors. And some patients who have hypertension for a long period and who are on medicines can have a deleterious effect on their semen parameters. Similarly, anti-epileptics taken for a long time can have an impact. And I see a lot of men with psychiatric problem who are on drugs also can have a negative impact on the semen parameters. So renal problems, liver problems. So any prolonged medical illness or medications that is taken for a long time can have an impact. And it is important that you rectify all these medical conditions before you start a fertility treatment. I've had so many instances, like even today, a couple had come to start an IVF treatment. They were insisting that you start this month. I found that his sugars were 245, random sugar. And when I asked, he said, I know I'm a diabetic, but for last 2 months, I didn't take medicines and I've been trying to control his diet alone. So I had cancelled the stimulation, asked him to control his diabetes, told him that if I do treatment with this high level of sugar, you can have problems in your offspring. So I had to really tell them not to start treatment and I postponed it to a month later. So this is why it is important that you evaluate the man on his overall general health. So most of the times we don't even check the BP of the husband. So it is important that you do a medical evaluation for the husband as good as what you do for a woman. Most of the times during treatment, I found a first time diabetic by this routine test, first time hypertensive also. So it is very important to screen the husband also. So addressing male infertility is an opportunity for these men to assess not only their reproductive health, but as I told you, their overall health in general with an emphasis on preventive medicine. So this is again, we found that a lot of men who might have had undescended testes are at a risk of malignancy. So in men with azoospermia, it is important that you counsel them to find out the cause of azoospermia. So the next problem with modern life, where we take everything with a touch of a button, is the obesity. Like people don't even walk stairs; they prefer lifts, and everything they want at home with the touch of a button. Now those Swiggy and everything, food also reaches you in a small cell. So what is the side effect of all this? Is obesity. And it has been found that men with obesity have got subnormal sperm parameters. It is essential that you counsel the husband how we counsel for a woman with PCOS to lose weight. Similarly, give the same amount of importance to the male partner to lose the extra baggage. So, this is how obesity can affect our fertility. So it operates through multiple pathways. Obesity is linked to erectile dysfunction, and this can cause stress, inflammation, sleep apnea, all of which can further bring a toll on the confidence level of the man. So there are a lot of papers which say that losing weight, maintaining the right BMI will help or enhance their fertility. This is another interesting area where I'm seeing practically where they've had their first child so easily, but they're struggling to have their second child. So this is something what they can't accept at all, especially when you ask the man to do a semen analysis for secondary infertility. Inevitably, every man asks you, Doctor, I have a child, as if we have forgotten that. So why are you asking me to do a semen analysis? So we have found that in quite a significant number of men, with time, probably there are multiple factors acting on them. They have probably had diabetes or hypertension later, or their work pressure, their mental stress, their medications, their diet has changed over time, obesity, as I told earlier. So, all these multiple factors could have caused a negative impact on their fertility. So, just like whenever there is a secondary infertility, we evaluate the woman, we check the tubes, we do a scan. Similarly, remember, you have to do a blood test for the man, check whether he has encountered the diabetes now or check his BP, do a routine blood test, and then please do a semen analysis also for secondary infertility. Okay. This is another very common myth. I would say this is more among clinicians than even patients, that a good abstinence is required to improve semen parameters or to even do a semen analysis. So a decade back, even I was believing this. But the real fact is that it is not so. So it is only the patients who have taught me that abstinence is not as really required. And I've seen that during an IUI, when the first sample is not good, when we request the patients whether they can give a second sample, it's only a request, we find that the second sample, which is given probably in an hour gap or so, is sometimes even better than the first one. So an abstinence of even few hours doesn't do any harm. So why do we have to stick with the textbook evidence? I mean, the older days of standard 5 days to 1 week or 4 days. And if it is not so, we don't even take a semen analysis. So when the egg's life is only 24 hours, especially during an IUI, why should we ask the couple to stay away for 4 days before an IUI? What if your egg ruptures just 1 day prior, and when you do a scan, you find that the follicle has ruptured? We don't even know when it has ruptured. At least if they had a contact the previous day, there would have been some sperms to take care of the egg. So especially during an IUI, evidence says that there is no need to have maintain abstinence, the standard 4 or 5 days, to have a better semen parameters. In fact, the reverse has been found to be true. This is a very interesting paper which says that shortening of the abstinence period may be beneficial to sperm quality. So, this study actually says the current guidelines regarding the prescribed abstinence period should be revisited. So, nowadays, I don't send back the patient if they say they have had contact just yesterday. And if they want to do a semen analysis today, I go ahead. But if there is a, say, azoospermia or a severe OATS, we always repeat another sample. So the strict abstinence criteria is no more standing tall. In fact, lesser the abstinence, they find that the motility fraction of the sperm parameters actually good. You may have a decline in the semen volume, you may have a decline in the semen concentration, but the motile fraction, which is very important to us, which is going to give us a result, gets better with shorter abstinence. So, decline in semen volume and sperm concentration with shorter abstinence period is accompanied by a good effect, that is a substantial improvement in sperm motility characteristics, especially progressive motility and velocity. So coming to the always a burning question, varicosilectomy, when it should be done, for whom it should be done, and what is its effect. There were times when a man walks into your consulting room who has oligospermia and the scan shows varicocele, be it a grade 1 varicocele or even a subclinical varicocele. Clinicians will jump to saying, you please undergo a varicosilectomy and your sperm parameters will be good and you will conceive. But what evidence says now? Clear-cut, straightforward indication for varicosilectomy today is only for symptomatic grade 3 varicocele. For subclinical varicocele, there is no role for varicosilectomy. What is subclinical varicocele? Where clinically you don't find a varicocele, but in your scan you find a varicocele finding. So for subclinical or a grade 1 or even a grade 2 varicocele where the patient doesn't have any symptoms, you don't do a varicosilectomy just to improve the semen parameters. With the advent of ICSI, where you can give a positive result even for a sperm count as low as 1 million, surgery takes a backseat, because if you do a varicosilectomy and your sperm count doesn't improve and you don't expect 1 million becoming 10 million or 15 million after surgery, then again he has to come back to ICSI only. So for severe OATS, when there is no symptomatic varicocele, the ideal option would be to either go for an IUI or an ICSI based on the sperm count. So this is another myth where the moment azoospermia is diagnosed, you find a man, most of the times I see the man losing his self-confidence, self-worth more than the women, because as I told you, they equate it to masculinity and they feel that they are no more a man. So which has to be addressed psychologically, probably better with a psychologist for the man. So the first thing that you have to do for the man is to make him understand that it is not his fault, neither this is equivalent to his masculinity, and azoospermia is not a dead end at all anymore. With the advent of testicular biopsies, especially micro-TSA, almost, I would say, 7 out of 10 men with azoospermia can have a chance to have their own genetic child. And especially if it is a non-obstructive azoospermia, the pregnancy rates are very good with just a needle aspiration of a PISA, percutaneous epidermal sperm aspiration, or a testicular sperm aspiration. I've had beautiful embryos with sperms taken from the epidermis. So these are some studies about varicoceles. What is its indication? Where we have to do. This is again very interesting paper where they say with the advent of ICSI, the role of varicocele is taking a backseat. Varicocele surgery is taking a backseat. Now coming to the last one, the nutritional supplements, because a lot of men, the first question they ask is, whenever the count is low, doctor, give me some medicines and my count is going to improve and I'll conceive naturally. This is an important area has to be addressed both for the clinician and for the patient, whether supplementation alone will take care of the fertility issue. The fact is, just giving medications alone for a OATS and waiting for a year, there are a lot of people who wait for years together. They take everything and they just wait at home. Whether that will improve fertility, I would say no. It is a combined approach of your medications along with your timely treatment or with IUI or ICSI only will give you a success. Remember this one line, this mantra: fertility is a race against time, especially whenever there is a low sperm count or for women low egg count, that is low AMH. It is a matter of time. So medical treatment in parallelity with the treatment of IUI or ICSI is going to give a good result. So it is important for us to understand the role of medications, how it acts, so that we can know what exactly are we giving and what is the effect that you are expecting out of it. So I want to just touch upon all the supplements available and to understand what are the benefits that it can have on the male fertility. So the common thing, because I know there are umpteen number of drugs in the market, each one will say I have this component, I have this component. But only if we know what each component does to your system, we will be able to choose the drug correctly for the patient. So let's look at the most common molecule that is used, that is carnitins. So carnitins assist sperm metabolism as an energy source for spermatozoa, and it is also an antioxidant. And multiple studies have got results which say there is an improvement in the concentration, motility, and the morphological parameters. And the dosage recommended, the safety one, is up to 3 grams per day. So the next common drug, every molecule, every drug for male infertility almost contain this molecule, that is coenzyme Q10. So what does it do to your sperm parameters? If you look at it, we find that this has a demonstrable effect for the semen parameters, and mainly when the seminal fluid concentration is more, it has a beneficial effect on the sperm motility and the fertilization potential. And there is some natural food also which is rich in coenzyme Q10, that is your fish, organ meat, whole grain, and vegetables. And the dosage that is recommended is 200 to 300 milligram per day, and it is given as 12 milligram per kg per day. So folic acid, just like how it is useful for women, folic acid can have a role for men also, for their DNA synthesis and proper cell function, and a critical role in spermatogenesis. And there are mixed reports on its effect. And we can have natural sources like dark green leafy vegetables, your beans, eggs, and meats are rich in folic acid. And the next molecule will be glutathione, and it is one of the abundant antioxidant produced in the body, and it has got an important role in maintaining the exogenous antioxidants in its active form. It is shown to improve your sperm motility, improves your concentration, and decreases the sperm DNA fragmentation. And we have a natural source of fresh meat, fruits, and vegetables, and the recommended dose is up to 3 grams per day. And the oral availability is slightly on the lower side. There are also injectable forms that is available. And vitamin A, that is B-carotene, is a precursor of vitamin A, and the most important effect that we are believing on it is their antioxidant properties, and it has specific benefits on sperm production and function. And again, it's a gray area how effective it is going to be. And the dose is Recommended doses, it should be less than 10,000 international units per day. And vitamin C, again, there are studies which says it improves sperm quality. Mainly, it protects sperm DNA against oxidative damage, and it can work synergistically with other vitamins and antioxidants. The recommended dose would be 90 milligram per day and a max of up to 500 milligram per day. Like vitamin A and C, vitamin E also is a potent antioxidant. It has a substantial support for improving semen parameters. We have a natural source from vegetable oil, meat, poultry, and the recommended dose is up to 400 IU per day. And we can have increased complications if you give an excessive dosage. Anything in excess is not right. Selenium has got a role in maintaining the normal testicular development, spermatogenesis, and sperm function. And it is again some papers which say it improves sperm motility, concentration, and morphology. Especially, it works better when given along with vitamin E. And the optimal dosing is about 100 to 200 microgram per day. And its important source is meat, seafood, and egg. And it doesn't have much in the vegetables. Selenium is not present much in the vegetables. Mostly it is in the non-vegetarian source. Zinc has a vital role in testicular steroidogenesis, testicular development. It increases the sperm oxygen consumption and other functions. And it has got mild deficiency, can have oligospermia. So zinc therapy is associated with improvement in sperm motility, and probably it has a role in reducing the sperm DNA fragmentation. And the upper limit is only up to 40 milligram per day. So we have come to the end where I just want to summarize the important points. So abstinence need not be the strict days where it adds more stress to the couple. You can relax, and if they want, they can even have a daily contact. It's nothing wrong. And semen volume is another misconception where most of the men believe that when the volume is more, they feel the count is good. And the reverse, whenever the volume is less, they feel they don't have enough sperms. There are instances where some men would have given just few drops of fluid, but I've seen almost say 60, 70 million of sperms in those few drops. Whereas on the contrary, some men, the volume could be 3 to 4 ml, but there won't be even a single sperm in it. So sperm volume has got nothing to do with the functionality of the sperms. And as I told you, varicocele, remember the indications and its role. Varicocelectomy alone doesn't improve the sperm parameters dramatically. With ICSI becomes much easier option. Look at the man as a whole. Please evaluate him for thyroid, prolactin, because hyperprolactinemia can lead to erectile dysfunction. Check his BP, do a blood sugar level for him. Please take his general body condition also into account, because a lot of men with diabetes and hypertension have got fertility issues. And of late, the age at marriage also is being pushed for men from early 30s now to even late 30s. And the lifestyle, our diet, the way, the sleep rhythm, everything matters for fertility. And yes, we have a lot of molecules available with us. Let's know the molecule and its effect to guide the patients correctly. Thank you everyone for being part of this male infertility myths and facts. I thank Shield for giving me this opportunity, and any doubts or queries, I'd be very glad to address.
Yeah, ma'am. Thank you. Thank you for that wonderful presentation, ma'am. Yes, ma'am. Of course, infertility is often misunderstood condition, which is the reason there the stigma as well as mystery is always surrounding it, ma'am. So thank you for defining it as what are the myths available, what are the myths, and how it should be overcome. Ma'am, wait for 2 or 3 minutes for the participants to post.
Yeah, sure.
Like and during the period of this COVID, so there were many myths like if you are taking this corona vaccine or if you are affected that is COVID positive, there is a chances of male infertility, something like that, ma'am. So, what will be your comments on that, ma'am?
Yeah, I'm very glad you're asking a very updated question, the recent concern. So there are a lot of studies which has proven that COVID infection causes a negative impact on sperm parameters. So it has been proven, and we had a lot of papers also. So that is one thing. So during COVID infection, it is better not to start any treatment for the male partner. The second concern of whether they can take vaccine. Yes, vaccines are safe. Male partners can take the vaccine and start the treatment. There's no harm in taking the vaccine.
Thank you, ma'am. And ma'am, coming to the excess caffeine, some people used to take this lot tea, coffee, and this carbonated drinks like Coke, Pepsi. What will be
Yes.
the impact of those caffeine in male semen parameters, ma'am?
Yes. This is again a very day to day question that you have asked. In one line, I would say anything in excess is not good. In Tamil, they would say, Alavukku minjinal amridamum nanjagum. Same way, although some men say taking a lot of coffee keeps them awake and motivated, they find that caffeine also has a deleterious effect on the sperm parameters, especially the motility. So please limit your caffeine intake also.
Thank you, ma'am. That was a eye-opener session. We hope if the participants has directly participated, that is the normal patients, if they have directly participated, it will be a good session for them also, ma'am. Let's wait for 2 minutes, ma'am.
Yeah, sure.
And some married couples are waiting for 2 or 3 years, ma'am. Whether it's a good approach, ma'am. They used to say that they have married only 1 year before, 2 years before, so we can wait for 2 or 3 years. So that is also another one myth, ma'am.
Yes. Thank you very much for asking me this question, because this is my favorite message that I want to tell the couples. Because most of them, after marriage, they always take child as a granted thing. Yeah, it's going to happen. So you won't believe, every day I'm facing patients where they have willingly postponed their pregnancy, and when they start planning their pregnancy, it's not happening, and they come running to us and they find that there are instances. Even 2 days back, I saw a couple where the husband was found to be azoospermic. Just like as you are asking, they've been married for 3 years and they postponed for 2 years, and when they planned just 6 months back, it was not happening, and he was found to be azoospermic. If only they had addressed, or they had just evaluated, probably just after a year or so, when it is after their marriage, if they found their sperm count to be low, at least we could have helped them to have their own genetic child when it becomes too late. So I would strongly recommend that after marriage, please have a counseling. Before you think of postponing, have a general counseling and evaluation where we can do an overall checkup for both the male and the female partner. And if everything is normal, then probably you take your time. But if there is an issue, for example, if the woman's age is 35 already when she gets married, I would say please plan your pregnancy early, don't postpone. Similarly, the man has got a surgery, say for example, undescended testes in the childhood, hydrocele or hernia, or he had some injury in the testicles, or he had a malignancy where he had radiation or chemotherapy, or he's working in a place where he's exposed to radiation, or he's a cook. So, whenever there is a high risk factor, I would say after marriage, it is important that you do an evaluation, do a semen check. If it is normal, then think over and wait. If it is on the lower side, you have to speed up your work and get pregnant faster.
Thank you, ma'am. Uh, Ma'am, I don't find any other questions in the chat box, ma'am. So
Okay.
if you allow us, then we can end up the session for today's webinar, ma'am.
Sure. Thank you.
So thank you very much for spending your valuable time with us today, ma'am. That was really a wonderful session, ma'am. And on behalf of Shield, I'd like to thank the participants for spending their time with us today, ma'am. Hope today's session was really useful for them. Thank you, ma'am, and nice meeting you, ma'am.
Yeah. Bye.